I'm Michele Nadeem-Baker, and I am a CLL patient, but I'm also a medical journalist and a really passionate CLL patient advocate, and just trying to really help all of us understand better just what CLL is and SLL, and also in everyday language.
My name is Jeff Folloder, and I am a passionate patient advocate. And there's a reason for that. The reason is I am living an excellent life with CLL. And my goal, my mission is to make sure that others know it is possible to live a great life with CLL. A little bit about me. I love fast red cars. I love expensive whiskey. And I love sharing stories and learning about this ugly journey of cancer that I'm dealing with and helping people figure out better ways to deal with it.
Hi, everyone. My name is Catherine Ferguson. I live just outside of Boston. I'm a retired college professor. I'm a vet tech, and I work in surgery. And I'm also a CLL thriver. Not only surviving, but thriving.
So probably like the majority of you, I was pretty surprised when I was diagnosed with CLL and thrown into something called watch and wait, which made absolutely no sense to me. It was pretty illogical. The doctor said to me, he walked in, I had no clue there was anything wrong with me. And he said, you have the C word, but it's the best you can have. Doesn't that kill you when they say that? So, nothing made sense to me that how anything with cancer could be the best. And then he told me that he'd see me in 4 months and then I'd be fine. So all of this was pretty illogical to me, having to grasp all of this at once and understand. And I know I've heard from a lot of you that you've gone through similar things. But during this time of watch and wait, what I did is I got a second opinion, and then I started what I guess you would call front loading information. I was trying to find out the most credible places to go for information, but also the most current. And that's something we have to watch out for with Dr. Google. So I learned Dr. Google is not necessarily the doctor you want to listen to, and also to go to find where we can find some credible answers. And so in that time, I also found great CLL specialists, the latest in treatment, and it's good to stay on top of what those treatments are. So I made sure that I took a lot of stress out of my life, which my job was a 24/7 job. And when I tell you that, that's not an exaggeration. I slept 2 to 4 hours a night. Dr. Rogers, can you believe this, for years? Because that was my job. It was a global job. You probably do the same. And it's just that, I was just like, I think I need to get a little healthier. So I upped my game on working out and on eating healthy. And I started doing yoga and meditating and trying to do everything I could to be the healthiest I could be for when it was time to start treatment. And treatment didn't happen for some years. Dr. Rogers, when we're diagnosed, we really think we're supposed to be treated right away and aggressively. So first of all, why doesn't that happen for the majority?
Oh, yeah. So, and it is the majority of people diagnosed with CLL won't need treatment right away. And in fact, with people getting routine blood work now, so often the most common way to be diagnosed is getting a blood test and then finding out you have CLL without any symptoms. And I agree, it is very confusing for people when you're told you have a cancer, and most of the things you hear about all forms of cancer is that you have to treat it, catch it early, and be aggressive with treatment. And that's not really the scheme in CLL. So the reason for that is that we know that treating it earlier doesn't help people live any longer or any better. So way back when we used to use chemotherapy to treat CLL, there was more than one randomized study where they took people who were recently diagnosed with CLL that did not have any of the traditional reasons to treat it, like symptomatic lymph nodes or blood counts that were abnormal enough to need treatment. So they took people who were asymptomatic or minimally symptomatic with no issues that required treatment, and randomized them to either be observed and then get treatment when they needed it, or to get treatment right away with chemotherapy. And there was more than one study, and this is again back when chemotherapy was the thing we used. And actually, there was no difference in overall survival, which is how long people were living between the two groups. So people treated immediately and people treated or sorry, people treated when they needed it or people treated immediately had the same survival. So we know it doesn't help you live longer. And actually, it looked like there was a slight trend towards shorter survival in people treated immediately because chemotherapy is not overly good for people and they got chemotherapy they didn't need yet. So, the way I like to view it is CLL is not something that we can currently cure with conventional treatments. We expect people to live a very long and rich lifespan with it. And so, given that, why expose someone to side effects from treatment earlier? Because the sooner you take it, the sooner you get side effects from treatment. And why expose like the CLL cells earlier to agents they could become resistant to, shortening the amount of someone's lifespan where they might be expected to have their CLL controlled by targeted agents? So if you think about it, there's a couple reasons not to do early treatment because of side effects and risk of resistance to the treatment. And we know it doesn't help people live any longer. And in fact, it might help them live worse if they're getting side effects. So that's like the rationale on the science side behind watch and wait, which I like to call observation.
So do you know, is there a percentage of people that goes immediately into treatment?
Yeah, that's a good question. I do think that percentage has probably decreased over the years. So I'm sure someone has looked at that as a straight percentage, but I'm not sure that really applies anymore. But it is really the vast majority of people that are in watch and wait, at least for some time. It's a much, much less common thing to need treatment immediately.
So let me play back a little bit because I've listened to this and I've been dealing with this for 13 years and it still doesn't seep into my brain. 13 years ago, I was diagnosed with CLL. I knew the exact type of CLL that I had. And my doctor told me, we're not going to do anything. And I was gobsmacked. And yes, I really wanted to use that word today. It didn't make sense. From day one, we're all taught, okay, cancer, detect it early, find out it's there, attack it, beat it into submission, and go have a nice, long, wonderful life. Okay, fine. I was told that. And you guys sold me really, really well on that. And then it was time for treatment. And I did the treatment and I got 6.5-ish years of really great remission. And then I relapsed and I'm back in watch and wait. And I still don't understand why, with all the new cool stuff we've got going, why aren't we treating this earlier? Why aren't we doing something faster, stronger? I mean, we've been polite. We call it watch and wait. Some patients call it watch and worry. Other patients have much uglier names for it. What's the deal?
I mean, there's a couple of reasons for that. I will say, though, as a scientific question, they are repeating some of these studies with the newer drugs to see if this is still true, that it doesn't improve survival for people, which is how long they live with their CLL, to treat early. So those studies are being done. The German CLL study group has one with ibrutinib as an early intervention. And then there's one that's occurring in the United States called Evolve, that's looking at venetoclax obinutuzumab either immediately or delayed. So we will get more information about that. Those will take, because people live so long, it will take over a decade or more to see if there's a survival difference because people don't die, which is great. Um, I think that when you think about other types of cancers like colon cancers or breast cancers, the reason to find them early is that you can cure them. And if you don't find them and treat them earlier, people die of them. When you're looking at CLL, you've got a lot of people who, even though they have it, are unlikely to die of it. That's not everybody, but a lot of people, are unlikely to die of it. And we can't cure it. So you don't get to do treatment and go back to whatever indefinitely, right? So if you do treatment now, even with our newer drugs, these still have side effects. Anyone that thinks they're getting a treatment with no side effects, you never get anything for free, right? So why expose someone to risks of high blood pressure, diarrhea, and then also we know that once you start exposing CLL cells to these targeted agents we use, there's an amount of time that the disease will respond before the cells become resistant and their CLL comes back. So if you start treatment 5 years before you had to, that's 5 less years where someone's CLL could be controlled by that drug. So you might actually shorten someone's lifespan by giving them a drug that you didn't have to by either causing a severe side effect or causing their cancer cells to become resistant earlier. And those schemes for like screening, treat early, and I get asked this all the time. But what if my cancer has spread? What if the CLL has spread? How will I know if it's spread? And I'm like, okay, this is really hard because it's a blood cancer, right? So it goes everywhere the blood goes. And they're like, well, that's everywhere. And I was like, I know. And it's so upsetting to think that. Like, I can just see how upset people are by this idea. But for CLL, it's actually okay. We expect it to be everywhere the blood can go, and that doesn't make it any less treatable or make our therapies any less effective. So these conventional things that apply to solid tumors are not really the same as applied to these blood cancers. And then there's a huge difference between aggressive cancers that can be cured or cause symptoms immediately and some of these cancers. And just for context, I like to think I'm really old now. I'm potentially not that old. But I have some patients that were diagnosed with CLL when I was in high school and have never needed treatment. And it's been over 20 years, actually over 25 now. I'm getting old. So, and if it's hard to say that you can improve someone's life by treating early and aggressively when the last 2+ decades have been them living their lives without anything hurting them from the CLL. So when you see that, then you think, it's not a good idea to expose these people to things they don't need. You can't improve on feeling well, right?
So we're going to queue up Michele now, because what we've been talking about is literally the most debilitating part of CLL for me, is the mental burden of this. I mean, we can be candid with each other. Watch and wait is not a normal thing for anyone. And when you're told you have cancer and you're told you're going to watch, you're going to wait, you're going to have to be vigilant, you're going to have to go into observation mode, that becomes a mental burden. I will admit that I did not deal with that mental burden very well when I first went through watch and wait. What about you, Michele? I mean, how did the whole situation work for you?
That's when I met you, is when I was just like, and basically it was just like, and Jeff had been through treatment. I'm like, how did you do this? It's like, for me, I felt like I didn't have control over what my own body was doing. And that is really difficult, especially for someone like myself who really likes to be in control of things. But it's just like, I think I'm doing everything I can. Is there anything more I can do? No, there really isn't. And it just doesn't matter. And that is so difficult.
So Catherine, you've heard two of us blabber about how we didn't do really well with watch and wait. How'd you deal with it?
So I dealt with it about the same as you guys initially. When I was diagnosed, I was at one of the top hospitals in Boston, but when they said they weren't going to treat it, I was like, oh my God, I'm going to have to go to Dana-Farber. So I went for a second opinion over to Dana-Farber, and they told me pretty much the same thing. And I was like, God, because my personality is I'm a go-getter. I want the plan. I want to get it done. I want to get it started, and I want to get it ended. So for the first couple of weeks, I was it was probably all consuming for me, honestly. I could have went down the rabbit hole really quickly, but pretty soon thereafter, I think I kind of had an epiphany where one day I just thought, I could go out, walk off the curb tomorrow and get hit by a car. And then I've spent my last days on this earth worrying about when I might die somewhere down the line. So for me, that set something off in my head that, life is for living right now. And, none of us know what tomorrow brings. It's not a guaranteed for anybody. So for me, I try and just live my life. I'm basically an optimistic person in general by nature. So for me, I try and just believe that, I do the things that I can do for myself and stuff like that. I take care of myself. I listen to the doctors. I get my screenings. I do all the things I'm supposed to do and watch and wait. And, that's all I can do. And then I just continue to live my life. It's not always like that, but, for most part, it's been after the initial probably few weeks when, it was just like a head slam against the wall. It's been better. And I have to say the second time around, it's been much better.
Dr. Rogers, what have you seen from your patients here about, the emotional, the mental health standpoint, how dealing with watch and wait, and what would you say to their care partners about this as well?
I always think, especially because we get so many people now diagnosed at a time when they have no symptoms. Their, blood tests are abnormal. They get diagnosed with CLL. They don't need treatment and they had no symptoms and say they felt perfectly fine and had no idea something was wrong until this happened. For this group of people, sometimes I think the hardest aspect of having CLL is knowing that they have it. At least that's what I kind of imagine the experience might be. And I see people where the worst part of it for them is not physical symptoms, but it's living with knowing you have it. And I try to tell people, you're feeling well from this. I've said based on the disease features, I don't expect this to be something that shortens your lifespan, even though you might need treatment at some point. Please don't let knowing you have this ruin your life. Like, don't let just knowing you have this ruin your life.
I want to share just a little bit about my experience with watch and wait. This won't take long. I learned through going through all the questions and answers at the hospital that I chose that I wasn't being candid with my healthcare team. I believe the military says I was exhibiting a lack of candor. Well, the problem was I didn't know how to answer their questions. I didn't know what was important when they said, so what's going on? How are you dealing with things? Is there anything that we need to know about? Things like night sweats. I associated it with my love of Thai food. You eat too much hot chili, you're gonna sweat at night, right? No. Going through all of this watch and wait was learning how to communicate with my healthcare team. And not knowing what was going to be the tripwire for treatment meant that I was learning new things about communication. I started treatment when my doctors discovered that my fatigue had become so debilitating that I couldn't do the normal things that I needed to do in my daily life. I couldn't lift certain things. I couldn't stay awake long enough. I couldn't do this. I couldn't do that. That was the tripwire for, okay, watch and wait is now over. Now it's time to move into treatment. So explain to us what you're doing with all these questions and answers. What are you looking for? What is happening during this period? And what should the patients and their caregivers be looking out for?
Yeah, so there's a few things that we always look for. Like we always check people's lymph nodes, but just because we found some lymph nodes, it's okay. It doesn't mean you need treatment. But if people notice a bunch of lymph nodes everywhere that's bothering them and keep getting bigger, then that might be important that we should do something to improve that for them. And then we look at the blood counts, which, people don't usually see their blood counts between visits that often. And so that's something that's really important. But in terms of what people tell us, it's always good to hear about how people are functioning, if they have things that are interfering with their professional leisure or preferred activities. If it's fatigue, if it's something else. We always ask about night sweats. And then someone's like, yeah, like while I'm going through menopause, I'm like, right, so that's cool. But then there's people with night sweats where like everyone in bed with them is wet. Like, they're wet, their wife is wet, the dog is wet, they had to change all the sheets. And you're like, boy, that's actually a problem. And it's hard because people don't know that we think there's a difference between, oh yeah, my neck got sweaty at night because they got hot, versus like everyone in the entire bed with me is soaked because I'm so sweaty. And so those are the things we try to figure out by asking questions when people like come see us. And so finding out about night sweats is fine, and we can help people determine what might be normal, like you were saying, the Thai food versus not really normal, right? Like, hey, that's not from Thai food. Fatigue is the hardest because there are so many things that can add to someone's fatigue. Every once in a while, we get someone that has fatigue that's really quite severe, and it's actually sleep apnea. So we get their sleep apnea treated, and they're like, oh, I feel like $1 million. And you're like, boy, I'm glad we didn't treat your CLL because of that, because it's not going to fix your sleep apnea, right? So part of what we do when symptoms are reported are not like, oh, you have fatigue, you need treatment, but like, hey, I have like more questions about what's going on, what might be causing that. I had someone say I have fatigue, but I haven't slept, kind of like Michele was saying, she only slept 2 to 4 hours a night, right? I was an intern once, I remember that, and of course people are tired when, they're busy and they have something going on like that. So a lot of the stuff we look for is not only like asking those questions, but like severity and follow-up questions about some of those symptoms.
Are there any statistics on the average number of years on watch and wait for intermediate and high risk patients, and maybe for the different mutations? Is there like some kind of expectation for watch and wait?
Yes. So the answer is yes, there is. So, this has been done in more than one study where they've looked at time from diagnosis to first treatment. It's hard to like pinpoint from these studies what will happen to any one person, though. So these are studies that look at a group of people diagnosed with CLL and how long between the time they are diagnosed and treatment. Then they look at different disease features, so high risk features like deletion 17p in the CLL, low risk features like IGHV mutated status. And then they look at the median, which is, you can think of median a little bit like average. It's not exactly the same thing, but like the median number of time for like the 100 people in that group to start treatment. So for things like deletion 17p, the median in one study was around 1.5 years between diagnosis and needing treatment. But within that group, some people needed treatment right away. Some people didn't need treatment for 5 years. And then so there's a staging system called RISE staging that can help predict time to first treatment, but you never know what's going to happen for an individual person. So I try not to get people too wrapped up in that because you don't know how it's going to turn out for them.
What an incredible panel. The four of you have made it such a rich conversation, and thank you so much for doing that. So we're going to have more programs. We're going to have, and Jeff, Michele's co-hosts. Thank you so much for being here, and we look forward to more programs and more conversations together.